So I shall be speaking on basically SICS in glaucoma patients, and in all these patients, depending on the degree of the severity of glaucoma and the severity of cataract, our management tends to differ. And whenever we are doing cataract surgery in these patients, the problems can be, there could be a shallow AC, there would be presence of synecdoche because of multiple attacks of angle closure or a previous trabeculectomy that may lead to synecdoche formation. The pupil may remain small due to prolonged use of pilocarpine or again formation of synecdoche. The iris may tend to be floppy. And if there is a pre-existing trabeculectomy, the patient may have a hypotenuse eye. And we all know that for the nuclear delivery, it is pertinent to have at least a normotensive eye for the nucleus to come out. So these are the issues that one needs to think about when doing a cataract surgery. So just to share, this is a case of a pre-existing bleb. This is a case of grade 4 nucleus with angle closure glaucoma, chronic ACG, and a pre-existing bleb. And the other problem that we can see here is the extremely shallow fornices. Even this is the medial end actually, and even the lateral end, as you can see, there's no place to work. So despite the fact that one has to change the side, I had to actually put a suture here. The other option was to do a lateral canthotomy to create a place so that we could dissect the tunnel. So this is the tunnel dissection with, I of course, being a pupil of Dr. Malik, trained under him, I do exactly the same surgeries, and this is the same way. Only thing is, what you observe here is that despite a very large capsular rhexis, the nucleus delivery from the bag into the AC was difficult, and because of the synecdoche, a two-handed maneuver is being used to bring the nucleus into the bag. So one again has to be careful that you should inject viscoelastic repeatedly so that this hard nucleus doesn't touch the endothelium. So this is the injection of viscoelastic. Now, sometimes in these patients, because of the bleb and the hypotony, the hydropressure created by ACM does not suffice, and the nucleus does not move because enough hydropressure has to be created. So I have used microvectors to assist my delivery in this case. And this is why we advocate that one should be well conversant with all the kinds of SICS technique, because no one technique is going to fit all the cases. So one must know when to interchange. Now, many a times we would offer a combined surgery, and these would be when there is a borderline control despite maximum tolerated therapy, and the patient is not able to tolerate the side effects of these drugs, or is a non-compliant patient, especially when you go to the periphery and you don't expect the patient is going to follow up every 3 months to get an IOP check. So it is best that you do a one go surgery so that the patient, at least we are able to save the eye. Also, sometimes there would be patients with a very poor media due to lens-induced glaucoma. So this is a flying eagle technique, again, Dr. Malik's innovation, where, this posterior end, this projection is akin to this flying eagle's tail. So we have again published this report, and I'll just show you a clip of how we go about doing it. So nowadays, instead of going for a fornix space flap for conjunctival peritomy, we use a limbus-based flap. The advantage is that we can suture this together, and it prevents prevents the leakage. Also, we are able to save the stem cells which are next to the limbus. So also we don't want to injure the conjunctiva much. So the conjunctival dissection should be minimal, just enough to allow a good entry of the anterior chamber, and it should not be a very large dissection, so that we have a place for a future trabeculectomy if required. So this is the dissection of the tunnel, and as described earlier also, has to be, the tunnel dissection has to be very careful. This is a patient where you can see the Herbert spits. So sometimes you have a problem in dissection, so you have to be very patient when you're doing this, because old trachoma scars hinder the dissection of the tunnel also. So this is the anterior chamber maintenance being used again, and After this, it is again very important to have a good capsular rhexis when you're doing a combined surgery, because we want the IOL implantation within the bag. You don't want the IOL to be in the sulcus as far as possible to give very good trabeculectomy bleb at a later stage. So this is the entry with the keratome, and you can see that the entry is done nearly about 2 millimeter from the limbus, so that you have a triplanar incision. So the moment you enter, you can see the fluid is coming out. And hydro dissection, this already was done, and this is the nucleus being brought out. Now again, you can see there are some synecdoche on the temporal area. So two-handed maneuver is being used to gently bring the nucleus into the anterior chamber. And all the time one has to be careful that the nucleus does not touch the endothelium. This is viscoelastic being injected so that the nucleus finds its place into the internal incision and it has come out. So after that, the cortical wash is, you can just press the lip and the hydro pressure created by the anterior chamber maintainer flows out the cortical remnants. And this is the epinucleus coming out. And this is what sir was also showing. This is a beautiful technique, for cortical aspiration. The IOL has been placed within the bag. Sometimes this 12 o'clock can be removed after placement of the IOL. Now, this is how we do a trabeculectomy. This is a MVR blade. We don't use any punch. And if you watch carefully, a lip of the corneal section is left intact. So this is a very nice technique and to do. And you can just chip off this sclerostomy. And after that, this is the iridectomy being done. And the iris is deposited. So we put two sutures over here at the edges of the square shaped flap. This will prevent the against the wound drag and also prevent hypotony. So we always put these two sutures. It's a it gives a very controlled IOP post-op, and this is a very meticulous conjunctival suturing that you need to do to create a very good post-op bleb. So this part really becomes easy if you have a limbus-based flap like this, and at the same time you are also, so this is the conjunctival flap that has been sutured, and at the end you should do a bleb hydration. So you can see the bleb being formed on the table itself. Just to conclude, we had published this study in 30 eyes, and there were no intraoperative or post-operative complications, and the surgically induced astigmatism was less than 0.5 in all the eyes. The mean IOP reduction was nearly 14 to 15 millimeter of mercury, and the advantage of this technique is the intact anteriorly and placement of scleral sutures that prevents against the wound shift and post-op hypotony. Thanks so much.